Hello, my name is Pedram Tabatabaie. I'm a senior consultant at the neurosurgical department of the University Hospital of Northern Sweden. Today I will give you a talk about DRG stimulation, patient selection, and clinical evidence. Let's start this presentation by talking about patient selection and success factors for DRG stimulation. The treatment algorithm for pain patients is fairly consistent worldwide, but there have been some changes over the past decade. The most notable shift is that physicians are now more cautious with opioids prescriptions, particularly for neuropathic and nociplastic pain conditions. Additionally, stimulation therapies are being introduced earlier in the algorithm, preceding the use of pumps and opioids, but following less invasive treatments. In this slide, in the green circle, you can see the best indications for spinal cord stimulation based on evidence. PSPS2, previously known as FBSS, PVD, and angina pectoris are known to be very good indication for spinal cord stimulation. In the blue circle, you can see the best indications for DRG stimulation. These include chronic neuropathic pain after surgery, trauma, or radiation. We have CRPS2, also called causalgia. We have postherpetic neuralgia and post-amputation or phantom pain. We also have the overlapping area where both therapies are considered equally effective. These indications include CRPS1, peripheral neuropathies, including diabetes, polyneuropathy, and chronic low back pain. This also covers PSPS1 patients, referring to those with non-surgical back pain. The indication with clear evidence for DRG superiority over SCS are CRPS1, CRPS2, and chronic post-surgical pain. In clinical practice, CRPS2, also referred to as causalgia, and chronic post-surgical pain are closely related. In my experience, these conditions can often be managed similarly from a neuromodulation standpoint. However, in research or pain rehabilitation settings, there are some distinct differences between these diagnoses, which should be taken under consideration. Here you have recommendations by the Neuromodulation Appropriateness Consensus Committee on targets for different pain locations. These recommendations are from 2019, so I have added T12 as a target for low back pain. This was not identified yet back in 2019. The contraindications are the same as for other neuromodulation therapies, such as SCS. Basically, you should exclude patients with severe psychiatric disorders, addiction problems, or significant cognitive deficits. These groups can't simply manage to take responsibility for the therapy once they have left the hospital. Compliance from the patient side is one of the key factors for a good outcome. Patient selection and overall medical decision-making in your practice should be standardized. Decisions should be grounded firmly on evidence rather than relying on daily intuition. It's also important to regularly evaluate the foundation of your decision-making process to continuously improve patient selection criteria. This is my algorithm at our practice. This is how I choose my patients for DRG stimulation. First of all, I want to see a local neuropathic pain. The pain should be chronic. The pain spread should be of maximum 3 dermatomas. There shouldn't be any prior surgery at the actual level, and the epidural conditions should allow access to the targeted DRG. I don't want to have any obvious foraminal stenosis at the level where I target my therapy, no obvious other contraindications. If all these requirements are met, then I will go for DRG. Other critical success factors beyond patient selection include surgical volume. You should aim to perform at least 10 implants per year to maintain the necessary skill level and experience for optimal outcomes. You should also establish routines at your practice to minimize risks and enhance care quality. Adhere to your routines. Routines are only effective if consistently followed. Evaluate your routines with regard to outcomes. Continuous improvement is often required to achieve excellence. Be a boring surgeon, not a creative one. Boring surgery is safe surgery. So, we have now talked about patient selection and also success factors for better outcome. Let's now go back to the main subject and go through some clinical evidence for DRG stimulation. Here is the first publication that I want to share with you. This is the ACCURATE study, which gave the manufacturer their FDA approval and the superiority labeling for DRG when compared to SCS. This study was performed by Deer and his colleagues and published in Pain year 2017. The objective of the study was to evaluate the safety and efficacy of the DRG stimulation compared to traditional SCS for subjects with CRPS or causalgia. And this was a prospective randomized controlled multicenter study of 152 patients. The patients were divided in two groups, one DRG arm and one SCS arm, and the outcomes were compared. The patient cohort were chronic intractable pains of the lower limbs. So the primary endpoints of this study was a composite of safety and efficacy. The subjects were considered a primary endpoint success if all criteria were met. The first criteria was a more than 50% pain relief in primary pain area. That was the efficacy. And the second was that the patient should have a freedom from stimulation-induced neurologic deficit through 3 months. And this was the safety aspect of the primary endpoints. The secondary endpoints were positional effects of paresthesia at 3 months between groups and percent pain relief in subjects with and without paresthesia at 3 months. And for tertiary endpoints, they looked at a bunch of different quality of life measures. So they could show in this study that 70% of DRG patients achieved more than 80% VAS improvement at 3 months. In the control arm with SCS, that figure was only 52%. Further, only 5% has paresthesia outside the painful area. Of course, programming guidelines for DRG suggest subparesthesia stimulation. In the control arm with SCS, almost 40% of the patients had paresthesia outside the painful area. They could also show great improvement in general health, social health, and mood disturbances. DRG was generally superior to SCS in all the analyses performed. And when it came to safety, there was no significant difference between the two groups. So the results showed that almost all DRG patients received a more than 50% pain reduction. 70% of the DRG patients achieved more than 80% of VAS improvement. Only 5% of DRG patients had paresthesia outside the painful area compared to 40% in the control arm. So greater improvement in general health, social health, and mood disturbances could be seen in the DRG group. So the key takeaway of this study was that you have a high responder rate and that DRG is a safe treatment option, giving a significant pain reduction. There were improved quality of life, and there was a proven superiority for DRG when compared to SES. Here is another very interesting publication from Dr. Deer and his colleagues. The objective of this study was to conduct a pooled analysis to investigate the generalizability of DRG outcomes and to identify differences in outcome between chronic pain etiologic subgroups and or pain locations. So basically, they wanted to see if there were any difference between different pain locations or pain etiologies when the patients were treated with DRG. And the results showed that independent on the pain location and the pain etiology, there was a high responder rate and a very significant pain reduction for DRG stimulation. Here you see some of the results from the study showing excellent pain relief independent on indication or pain area. There was also significant improvement in other quality of life measures. So the pooled analysis just presented to you tells us that DRG is a unique therapy where we more or less can target any pain location. And as long as there is a neuropathic pain in that area, we will have a good chance of success and pain relief for our patient. Today, there are consistent data from across the world which shows that DRG works well in all kinds of different settings and for different indications. Independent on pain location or etiology, DRG stimulation seems to have a good effect on neuropathic pain. There are also data today ensuring the longevity of the therapy. For example, at our center, we have today 5 years data showing that DRG stimulation is a very stable therapy over time. Let's now focus on some indications that I believe are the best indications to start with if you are interested in starting with DRG therapy. So one of the best indications are chronic post-surgical pain in the foot and the knee. So we know that risk for nerve injury are high for knee surgery due to high anatomic variation in the density of the branches of the saphenous nerve. This results in high incidence of peripheral nerve damage after knee surgery. Here is an algorithm for how to treat post-surgical pain after knee surgery. And I'm not saying that all patients that have a post-surgical pain should be treated with DRG stimulation, but the ones that have a neuropathic pain and that have undergone other less invasive treatments without any good result should be considered for DRG stimulation. Here's a publication from Professor Morgalla and his colleagues. The objective of this study was to study the long-term outcome of DRG use in treatment of chronic neuropathic pain. The patients in this group had different pain locations, but the majority of the patients were knee or foot patients. In this study, they could show an almost 80% pain relief for the foot pain and the knee pain patients at 1 year. At 3 years, there was a 64 to 69% improvement in pain intensity. Also, other life quality measures were analyzed in this study, and they all showed significant improvements and stable results over time up to the 3-year follow-up points. Moreover, 70% of the patients reduced or completely stopped pain medication. Here is another study from Kretschmar and his colleagues with patients suffering from chronic neuropathic pain. They could in this study show that there was a significant reduction of opioids use after the onset of DRG stimulation. Of course, they could also show improved life quality, increased function, and decreased pain intensity. Let's now go to the next indication, which I believe is a very good indication for DRG and also suitable to start with if you are new with the DRG therapy. There are evidence that around 5% of patients undergoing hernia repair or other abdominal surgeries will develop a chronic post-surgical pain condition. When it comes to growing pain, the nerves involved are mainly the genitofemoral nerve with its branches, the ilioinguinal nerve, and the iliohypogastric nerve. The areas involving these nerves can be targeted by stimulating L1, L2 mainly, and in some cases also T12 and L3 levels could be of interest. Here is still another algorithm for how to take care of patients with the post-surgical pain. And in this algorithm, we are looking at patients with growing pain. Again, I'm not saying that all these patients should be treated with DRG stimulation, but the ones that have a neuropathic pain condition and that have tried other less invasive treatments and still have a very severe pain, they should be considered for DRG stimulation. Some of the studies in this slide which I showed you earlier are on growing pain and abdominal wall pain patients. And as you see, the results of these studies are comparable to the other studies on the slide. Safety is, of course, extremely important when you introduce a new therapy. In this last section of this talk, we will talk a bit about safety and complications. DRG stimulation is more difficult technically than spinal cord stimulation and should only be performed by a more experienced implanter with higher volumes. Here is a study from Dr. Deer and his group where they analyzed safety data for DRG stimulation and compared it to spinal cord stimulation and other epidural neurostimulation devices. The data analyzed were safety and complaint records for DRG stimulation and spinal cord stimulation obtained by the manufacturer. They also compared this data with published data on complications. So looking at the complaint and safety data from the manufacturer, there were no significant difference between DRG stimulation and spinal cord stimulation. Also comparing the complication rates with published data showed a safety profile similar to spinal cord stimulation. In my own experience, the complication rates are a bit higher for DRG stimulation compared to spinal cord stimulation. The main issues we have encountered are electrode dislocations, where we have a complication frequency of around 6 to 7%, which we regard as acceptable. We should bear in mind that DRG stimulation is only an infant therapy, being around less than a decade. We are still using the first generation hardware. I believe that both hardware and the technique must be developed further and improved in the future. As a last slide and a summary, I'm going back to the results of the ACURATE study, which really can show superiority of DRG stimulation compared to spinal cord stimulation. DRG stimulation have a robust effect on pain intensity and other quality of life measures with high responder rates. I hope that you have found this presentation insightful. Thank you for listening to me.